Bismillah ar-Rahman ar-Rahim. It's my pleasure to join the annual meeting of Egyptian Society of Hypertension, and I have to thank my chairman and the organizing committee for inviting me to participate in the meeting. I have to thank Novartis also why we are choosing this subject, patients with heart failure with preserved ejection fraction. In our hypertensive patients, we know that a good sector of our patients with hypertension they have impaired diastolic function. Therefore, this subject is our interest today. Our agenda comprises several points. The first, I'm going to touch what's the HFpEF, or the heart failure with preserved ejection fraction, and the clinical characteristic of such kind of patients, and why it's important, and why we choose this category of patients to discuss today, and how to settle the diagnosis of this situation, and the most important, it's the way forward in the management of heart failure with preserved ejection fraction. Let's go rapidly in defining patients with heart failure with preserved function according to the reports of Heart Failure Society of America, Heart Failure Association of the European Society of Cardiology, in addition to the Japanese heart failure. We have to settle the diagnosis first by the symptoms or signs of heart failure caused by structural and or functional cardiac abnormality. In addition to at least one of the following, the elevated natriuretic peptides, and the objective evidence of pulmonary congestion or systemic congestion. Accordingly, they divided patients and they categorized patients with heart failure into 4 main groups, not 3. First group, those with reduced ejection fraction, frankly reduced ejection fraction less than 40%. Second group with mildly reduced ejection fraction between 41 and 49. Third category, those with preserved ejection fraction, more than 50% ejection fraction. Fourth group with improved ejection fraction. Those patients were starting with baseline reduced ejection fraction, and by treatment, they improved more than 10 points increase from baseline and approaching 50% ejection fraction. So, we are dealing today with the third group of patients, those with preserved ejection fraction, or as an abbreviation, HFpEF patients. What's their clinical characteristics? First, we have to know the prevalence of heart failure with preserved ejection fraction. The HFpEF region, as we can see here, those patients with HFpEF, it's increasing with age, and it's more common in women. So it's higher in females. What about the comorbid conditions? They found that patients with HFpEF more frequently had higher number of comorbidities, diabetes, hypertension, dyslipidemia, etc. And when they look to the characteristic features of HFpEF patients in the different research and the clinical trials, they found that this kind of patients, the age and it's more above the 70 years of old, and they look to retrospective and registries in addition to prospective studies. And they concluded that mean age between 74 and 78 years old. Majority, they are women. It's more than HFrEF. Hypertension, much more common in HFpEF than HFrEF. Coronary artery disease is more in HFrEF. AF, more prevalent in HFpEF than HFrEF patients. Diabetes, almost the same. And body mass index, it's more in HFpEF patients. And why it's important? Why we are giving this important attention to HFpEF patients? As you can see, here in the optimized trial registry that was conducted over 41,000 patients and was published in JACC in 2007, you can see On the left side, that patients with HFpEF almost have patients with heart failure. So it's a big category of patients. And look to the trend in the prevalence of heart failure. As you can see here in patients with reduced ejection fraction, with time there is no change almost in the prevalence of HFrEF. But look to patients with HFpEF, there is increase by 1% per year relative to HFrEF patients. In 2020, it's expected that 65% of hospitalized heart failure patients will have ejection fraction more than 40%. Again, about the incidence of heart failure, they look to the incidence of heart failure in patients between the year 2000 up to 2003, and it was around 47.8%. And then when they compared the same category of patients at the year 2008 up to 2010, they found that increasing number of patients, it was 52.3%. This means that the incidence of the heart failure with preserved ejection fraction, and they found that the prevalence of the comorbidities such as hypertension, diabetes, body mass index, dyslipidemia, all these comorbid conditions, they increased over time. What about the size of the problem, the magnitude of the problem? HFpEF is a major public health problem. Look to patients with HFrEF, with improvement of therapeutic modality of heart failure patient with reduced ejection fraction. There is improvement in the outcome of such kind of patient. But look to on the other hand, look to patients with HFpEF. There is no improvement in the outcome of such kind of patient as there was no addition of therapeutic modality. Again, about the rehospitalization due to heart failure. As you can see, here the rate of readmission is higher than the other cardiovascular causes for readmission in patients with HFpEF. Maybe not due to cardiac causes, but due to the non-cardiac causes, such as renal complications, neurologic complications, diabetic complications, respiratory problems due to the increased body mass index. So the incidence of complicated course and repeated admission in general in such kind of patient is higher. That's why we are giving the attention to this category of patients. The most important, when it happens. Look to the quality of life. Patients with HFpEF, they are supposed to have normal systolic function and they are supposed to have normal activity, performing normally in life, but it's not the case. There is limitation to the activity and there is diminished quality of life due to the shortness of breath, which is limiting their usual activity. This takes us to the question, is HFpEF just a mix of comorbidities or it's a special entity? We look to the cardiovascular trials compared to the heart failure trials. Here are the cardiovascular mortality in the cardiovascular trials in general. Here it's on the right side, those trials dealing with patients with heart failure and HFpEF. Look to the mortality, how is much higher than the other cardiovascular research studies. In addition to the heart failure rehospitalization, again, here the incidence of readmission much more in patients with HFpEF. How to diagnose it? As it's that important and the patients, they are liable for complications. How to settle the diagnosis. We have international guidelines to recognize the complexity of diagnosis and non-specificity of the symptoms, and it needs objective evidence. We have to have objective evidence for the HFpEF. The European Society of Cardiology and American Heart and American College of Cardiology guidelines settling the diagnosis. We have to First, symptoms to settle the symptoms and typical symptoms of heart failure. Signs are typical of heart failure, and normal or only mildly reduced ejection fraction. We have to settle the diagnosis by objective data, and will depend on two main parameters: the lab, which is the pro-BNP, and the imaging modality, which is the echocardiography, which is a cornerstone in settling the diagnosis of patient with HFpEF. What about the other modalities? We have CMR. As I mentioned, here is the cornerstone, the echocardiography to settle diagnosis, but the CMR now, it's a rising imaging modality in establishing the accurate assessment of the systolic and diastolic function. And what about the invasive hemodynamic? Invasive hemodynamic, why it's indicated in such kind of patient? It's indicated to accurately measure the filling pressure of the left side and the right side, but it's rarely indicated. So we have to settle a score for the diagnosis of patient with HFpEF. First, the initial workup, the symptoms, the signs, the comorbidities, and to see if the patient, we have to subject him to ergometry or cardiopulmonary exercise test, ECG findings. As I mentioned, the standard echocardiography and natriuretic peptides, these are the cornerstone for the initial workup. Then the diagnostic workup by echocardiography and natriuretic peptide, we have to settle the diagnostic procedure. When we need advanced workup, further workup to settle the condition, to assess the diastolic function, stress echo, or assessment of the wedge pressure. Etiological workup, we might need, as I mentioned, the CMR or the scintigraphy, myocardial perfusion imaging, PET study, CT, genetic testing, biopsy, whether it's, for example, sarcoidosis or amyloidosis, but up to the moment, still the non-invasive procedure to settle diagnosis, it's the cornerstone to assess the diastolic function. Again, the HFpEF score, first we have to look to the body mass index. If it's heavy, more than 30 kg per square meter, we give 2 points. If the patient's hypertensive, 1 point. AF, 3 points. And pulmonary hypertension, 1 point. If the age above 60, it's 1 point. The filling pressure is documented as high, it's 1 point. So the sum, if we have more than 5 points, it indicates definitely the patient is HFpEF. What about management? Management of such kind of patient. What about the guidelines? ECC guidelines in 2012, there was no specific treatment for patients to reduce the morbidity and mortality of HFpEF patients. What about in 2016? Again, the guidelines didn't give us a definite treatment to improve the mortality. What about the new therapeutic modality dealing with the patient with heart failure with reduced ejection fraction, which is Sacubitril, Valsartan? It's the first class of ARNI, and it's well documented and was approved by FDA and all the societies for treatment of HFrEF patients. Is it have a place here in treatment of HFpEF patients? Let us see what's the mechanism of action. Here, it's 2 parts of the molecule, the Valsartan, which is the angiotensin II receptor blocker, which will lead to vasodilatation and improving or lowering the blood pressure, sympathetic tone, and also aldosterone level, myocardial fibrosis, and ventricular hypertrophy. And the neprilysin inhibition will lead to, vasodilatation, decreasing myocardial fibrosis, and natriuresis. So combination of the 2 together definitely will intensify the effect. Do we need it in HFpEF patients? Let's go to the pathology of HFpEF. What's the mechanism? What happens to patient with impaired diastolic function? The protein titin is the dominant regulator of myocardial tension, and thus of the cardiomyocyte-derived stiffness. Titin is functioning as a bidirectional elastic coil. Titin shifts from compliant isoform, which is N2BA, towards the stiff isoform, which is N2B. It has been postulated to contribute to diastolic function in HFpEF patients. So, the modification of the titin N2B segment by the GMP, cyclic GMP, this might help or may contribute to improving the diastolic function, as it makes the shift of the titin from the stiff isoform back to the compliant isoform. This may improve the passive tension. Accordingly, this may improve the diastolic function of the left ventricle. This is the concept of thinking of using the Sacubitril, Valsartan in trying to see if it's beneficial for HFpEF patients or not. Here in the trial conducted by Sloman and was published in The Lancet in 2012, they conducted this study, Valsartan in one limb against Valsartan, Sacubitril Valsartan in the other limb. It's the first trial that comparing two drugs against each other. And they found that there was improvement in natriuretic peptides, and it was definitely in the benefit of the patient used the Sacubitril Valsartan. Also, when they looked to the left atrial size, those who received the Sacubitril Valsartan, there was reduction in the left atrial size, and the difference was statistically significant. Again, the improvement in NIHA class, which is very important, it's our target to improve the NIHA class of patients with PAF-HF and to improve the quality of life. And they found that it's for the benefit of patients who received the Sacubitril Valsartan group. This is the Paramount study. As I mentioned, these were the main results. Then the Paragon heart failure trial. It was the first randomized trial of HFpEF patient designed versus an active comparator. All previous trials had either ACE or ARBs or aldosterone antagonist against placebo. And they conducted the study by screening up to 2 weeks, then Valsartan 80 milligram twice daily for 1 to 4 weeks, and checking the safety and tolerability, and then dividing the patient to either Valsartan alone, 160 twice daily, or Sacubitril Valsartan 2 milligram twice daily. And they did follow up for the patients to see the benefit of either two drugs. And what about the results of this Paragon heart failure study? And it was designed to compare the HFpEF studies, all of it, against Sloman et al. In 2017. As you can see here, the treatment, as I mentioned, against it was single drug against placebo, and the NIHA class was between the second class up to the fourth. They measured the natriuretic peptides, and they were looking for the cardiovascular death and the rehospitalization. This is the primary endpoint. And look to the result. There was 13% reduction in the risk of the primary endpoints in those patients who received Sacubitril Valsartan. And the study was followed up to 4 years. Again, the sensitivity analysis revealed that the risk ratio, the hazard ratios and benefit of the patient, they received Sacubitril Valsartan. Look here to the NIHA class. the improvement of the patient who received Sacubitril Valsartan happened in 15%, while in Valsartan alone it was in 12.6%. And this study was that this difference was statistically significant. Can I have 2 minutes, please? 2 minutes, please. And then the renal, and I'll touch the important points, worsening in the renal function was less with patients who received Sacubitril Valsartan, and the difference was statistically significant. All-cause mortality here, it was statistically non-significant. Again, in the circulation, the original study that was published in 2020, and it dealt with the Sacubitril Valsartan across the spectrum of ejection fraction in heart failure. And as you can see here, again, in Paradigm and in PARAGON studies, both Sacubitril Valsartan definitely could improve could improve the outcome, improve the primary endpoint, mortality and rehospitalization. With the greatest treatment benefit observed in patients with left ventricular ejection fraction below normal. Moreover, the treatment effects across the ejection fraction spectrum were further modified by sex, such that the therapeutic benefit appeared to extend to higher level of ejection fraction in women compared to men. This was the important observation, that women, they got benefit by improving the outcome than men. And in last February 2021, FDA had approved the use of Sacubitril Valsartan in HFpEF patients. And what's considered a normal ejection fraction? They considered a low ejection fraction defined as below 61% in women and below 55% in men. Take-home message that heart failure with preserved ejection fraction accounts for up to 50% of the patient. Halas, it's enough. Okay, thank you.